We should not ignore hypertension. The body has a capacity to heal on its own. It does not mean that only pork lovers will get cystitis. Even vegetarians can get it. During surgery, believe it or not, just with millimeter precision, the whole tumor was removed, and lo and behold, he started walking third day.
In your practical experience, without revealing the identity of the patient, can you share an experience where the patient had a headache which turned into a devastating event and finally, the outcome was very poor?
Well, there was one guy who was in the IT sector. He had some headaches right from his childhood.
Okay.
It was ignored. They said you are not able to study properly, and he was an extremely intelligent guy. And he had a problem repeatedly, which was probably ignored by his parents. And then one fine day, while he got married, he got a child, he was in the IT sector getting a good pay. And one fine day he overworked, and then early in the morning he had a severe pain, woke up with a severe headache. They said it's your routine headache, and he was conscious at that point of time. So, and then his headache increased and he became a little drowsy. They brought him to the hospital. When I saw, it was a huge arteriovenous malformation in the brain. He probably had it right from birth, and he has tolerated that sort of malformation which was there right from birth till his probably 30s, 35 years. And then they usually grow with time, and it was in a very eloquent area, that is in the motor cortex on the left side. So when there was a bleed from that arteriovenous malformation, and that bleed probably was because of his stress, and he started having some early hypertensive features. In such situations, they bleed, and they also can have present with a seizure. And we operated upon him, and it was an operable lesion. Nevertheless, he had some residual weakness of the right upper and lower limb. He had some speech difficulty. All those things was there, but he could not go back to his work, to his earlier schedule. Nevertheless, he was salvaged. He survived.
Okay.
That's one thing which I remember.
Hypertension is one of the most ignored things. People think it's take it for granted or take a over-counter medication for hypertension. They treat home remedies, go into different aspect of treatment not related to allopathy as well. When such hypertension is ignored, we have seen patient coming with intracranial bleed. What is your say on that?
Well, we should not ignore hypertension. And nowadays we see persons in a very young age group, 30, 35s, they become actually hypertensive and they need medications. Such situations, the myth is, oh, I have got a hypertension, doctor has started me on medicines, I have to take this for lifelong. I will start after 4 or 5 years when I'm 40. Then probably let us see. And during those 5 years, the amount of damage that this hypertension would have caused would be phenomenal. And if he is in a situation where he is very aggressive or he is a manual laborer, then the amount of blood pressure which rises with every physical activity also increases. And in such situation, we have seen so many young persons coming with large intracranial bleeds. And we sometimes don't enjoy because we think there could be an aneurysm as well. Because in such situations, if the person has an aneurysm and it has blood there, and it can't be picked up without doing an angio. So we need to treat this hypertension aggressively, and otherwise the amount of damage and the amount of lives it has taken is phenomenal. Hypertension and diabetes, both of them have to be treated very, very properly.
What is your role as a neurosurgeon in strokes?
Right from, it depends on whether the neurosurgeon is trained in stroke intervention, that is interventional neurosurgery. If it is an interventional neurosurgery, now the latest stroke guidelines 2026 has come in where the window period has been extended, right from 4.5 hours to 9 hours. You can give tenecteplase as well as a single shot. So when you are able to give that injections as a single shot, it can be done even in a rural setting. Okay. A person who is coming with a stroke, for example, if it's an infarct, First thing is we need to have a proper stroke unit wherein we have the neurologist, the neurosurgeon, the intensivist, and the paramedical staff who know about it. A stroke happens immediately, do a CT. If the patient has got blood in the, if there is no bleeding, then it is an infarct. So we go in with the schedule if he is in the window period. Sometimes if it is a large visual occlusion, or if there is if we have interventional neurosurgical team, a cath lab, we can as well go in and basket that particular clot out. Even if it is for 24 hours, even if it is an anti-circulation obstruction, even for post-circulation obstructions and basilar obstructions. It has been extended so much because of various trials. The last trial is there. The trials which are related to this, they have extended the period. Now the guidelines have come in very recently. So as a neurosurgeon, we can be involved in the initial stages of stroke management if it's an infarct. Suppose if it is an infarct which is fully established, then a decompressive neurosurgery with an expansal duroplasty, which is very commonly which we do. That saves lives, but it does not salvage the brain. And if it's a large hemorrhage secondary to a stroke, then evacuation of the hemorrhage, depending on where exactly the hemorrhage is, whether it is necessary, whether the patient has got a large hematoma which is causing compression of the brainstem structures, mass effect, midline structures probably being pushed to the opposite side. These are all indications where a neurosurgeon comes into play, where the clot is evacuated, or the infarct. If it is an infarct in the initial stages, an interventional neurosurgery can.
The publics are always confused between neurology and neurosurgery. Okay, they don't know whom to approach, whether to approach a neurologist or a neurosurgeon. What is your say on that?
There is quite a bit of overlap, because headache is seen both by neurologists and neurosurgeons. Hand pain, leg pain, they are seen by both neurologists and neurosurgeons. And hardcore neurologists of like myasthenia gravis, patients with having genetic disorders, mitochondrial problems leading to different chronic neurological disorders, spinomuscular dystrophies, all those things are definitely dealt by the neurologist. But certain symptomatic things, both of them see, and it is always a cross-referral. If you treat it conservatively, and if the neurologist thinks that it could be something which is a neurosurgical problem which probably requires an intervention, then it will be referred to us. Otherwise, if we see something where a patient has got some ataxia, some problem like that, or we find it is a pure neurological problem, then we send it to the neurologist for further evaluation. So there is a cross, that overlap is always there. And even if the patient goes to a neurologist or a neurosurgeon, doesn't matter, because both of them are knowledgeable into that particular situation. And if it is something which is manageable as a conservative management, it can be treated by both of them. If it is something which requires surgery, then fine, it will be referred to a neurosurgeon.
When it comes to spine, okay, there are many youngsters who are into fitness these days, okay, and who land up with a slip disc. Okay, there are many people who have got a back pain and have a disc problems. Okay, but are all the back pains end up with surgeries, or there are certain indication to go ahead with spine surgery?
See, 70 to 75% of all humans will suffer some back pain at any point of their time in life. All back pains do not require surgery. In fact, patients who even have discs, who even have listhesis, which is probably a fixed listhesis, not a mobile bar, 70 to 75% of those patients may not require surgery.
Okay.
There are well-established criteria, well-established cohort studies, which very clearly say all spine patients, all disc patients do not require surgery. It is only those cases which have persistent pain,
Okay.
progressive pain, some deficit, unable to walk properly, weakness of the limbs, not able to pass urine, or because they sit in the can, they're not able to pass at all. They find it difficult, or they have some severe constipation and some anesthesia in the low down near the perianal area. Such cases are an emergency, it has to be done immediately. Otherwise, the normal indications are if it has numbness, weakness, progressive pain, progressive deficit, which cannot be treated by medication, then they require surgery. And if the imaging also, there should be a correlation between the patient symptoms and the imaging, like the scans and the MRIs, which definitely indicate that this is a case which requires probably surgery. then it will go for surgery. Otherwise, it's a myth that all patients who have discs will require surgery. No.
And is it that the scans are compulsory for every back pain?
No, not necessary. If it is like how I said, if a patient has got some weakness or numbness or progressive pain only, many back pains, many neck pains subside on their own within 3 to 4 weeks. No matter what you do, whether you take medicines, don't take medicines, take rest, don't take rest, the body has a capacity to heal on its own.
Okay.
But if it is progressive, then it requires intervention in the form of investigation and surgery if it is required.
In a busy life today, taking a bed rest is impossible when a person is a sole learner. So with people with such back pain, needing to take bed rest becomes impossible. So what is your say on that? Like, what is
Actually,
your
bed rest
advice?
is not required. It's not there is no need to have a complete bed rest. Like when we were studying neurosurgery at that point of time, 25, 30 years ago, bed rest was indicated for back pain. Bed rest in the sense he is allowed only to sit for having his food, or he is given a can so that he can pee at the place where he is lying down. That sort of a bed rest. He should not move.
Okay.
You should not he can just turn around and you should lie in the bed all the time. That is a sort of bed rest that they were giving. But it is more harmful than beneficial. Pain is something which requires some movement. Movement is needed. So complete bed rest is not indicated in spine injury. Maybe a day or two of bed rest is necessary.
Okay.
So that to tide over the crisis, to reduce, for the pain to reduce. But complete bed rest for weeks together is not indicated. So it's not necessary.
That's a good information. Okay. When it comes to infection, of late infection is very common. Okay. The way other organs get infected, even brain gets infected as well. When exactly is a neuro intervention required for infection?
Infections, like it can happen in a very young age group. Some people without any problems, they start dripping from the nose. Watery discharge from the nose. It is called spontaneous CSF rhinorrhea. I have seen such patients who don't tell us that he's got a dripping. They come with a headache. They say, you've got severe headache, give some medications for 3 to 5 days, it subsides on its own. That probably is an infection, a meningeal infection in a subclinical form. And they think it is not necessary to tell that there's a dripping. It is just some common cold which I've got. Patient may not know it at all. So, and they wouldn't have had an injury also. It is spontaneous leak because there's opening the cribriform and they trip.
Okay.
Certain patients who are having tuberculosis in their earlier life can develop a resurgence of the infection which can go to the brain and then can cause tubercular meningitis. Suppose when their immunity falls due to severe diabetes or any reason for that matter.
Yes.
So such patients, we have to check whether there is an infection. Most important thing is they will have severe headache, neck pain, progressive weakness, their cognition comes down, their conscious level comes down, they're not able to think properly, they become more drowsy, and then they going for frank infection. Sometimes in patients who are actually having immunological problems, who are taking medications for cancer, so those patients' immunity is very less. So they can have an infection which can go from the lungs into the brain, which can become an abscess, like how it is in any other part of the body. They can have a brain abscess. And such instances, it depends on the stage of the abscess, whether it can be treated only with medication or whether it requires intervention at a later stage.
Okay. And what do you say for the meat lovers?
Well, cysticercosis was thought that people who eat more pork can get more of cysticercosis or more of infections in the brain. They are all parasitic type of infections, but it is not so. Even vegetarians can get that.
Okay.
It does not mean that only pork lovers will get cysticercosis. Even vegetarians can get it. That's a myth actually.
Okay.
But the incidence is probably more in them because if the pork is infected, it is improperly cooked, then they may get into that sort of thing.
Finally, the cancer is there in every house these days. It has become a part of lifestyle as well, where many families are dealing with it. So when it comes to brain tumors, what is your say on that?
See, brain tumors cannot be neglected. And every brain tumor need not be feared. Most important is there are two things. One, people should know: cancerous and non-cancerous. But it does not matter if it is a non-cancerous tumor in the brain, which is a huge one. If it's a huge tumor, which is not a cancer, it is not spreading. Like probably a benign meningioma or an acoustic tumor or neuroma, neurofibromas. They are not cancers. They are in the brain. But if it is present in an eloquent area, meaning if it is near the motor cortex, near the speech cortex, near the visual area, they can damage that area and cause deficit. So, nevertheless, even if it is a tumor, which is not a cancerous tumor, it has to be removed. Some malignant tumors, that means a cancerous tumors can happen in the brain, which can be a primary in the brain, starting from in the brain itself, or it can go from different parts of the body and spread to the brain. A patient having a breast cancer, liver cancer, lung cancer, colonic cancer, thyroid cancer, they have a primary in the body somewhere else, which can spread through the blood or the lymphatics into the brain and then can cause a cancer. So it cannot be ignored. And it has to be treated just like how we have management of cancers in the body. We have removal of the cancer tumor through surgery, then chemotherapy and radiotherapy, which is indicated depending upon the case. If it is a small tumor, it can act as well neglected. We have seen some incidentally detected tumors in the brain, like a patient who is 80-year-old who had a slip fall. He has slipped and fell down. And we did a routine CT scan and we found a meningioma in her brain. She is 80 years old. She has been living with that meningioma. It has not caused any problems. There is no problem with the surrounding structure. She is walking, talking, and there is no indication for removing it also. She will live with it for her entire life. It does not cause any problem. If it's a tumor which is very small, we can give a radiotherapy without surgery and it can slowly regress over a period of time. So it depends. So a cancer in the brain means death. It's not so.
Okay.
It depends on what type of cancer it is, what stage it is, and whether it's a benign tumor, whether it's a malignant tumor, whether it is salvageable, not salvageable. There's so many options. So there is no need to get disheartened.
How is this AI and robotics influenced neurosurgery?
Great way. Very great way. Initially we had this stereotactic surgery. Stereotaxy, in the sense we had to place in various fiducials in the brain, and then through that we had the XYZ coordinates and then localized these particular tumors in the brain or any object in the brain to pinpoint precision. That was stereotaxy, and that stereotaxy has given rise to what is called as neuronavigation nowadays.
Okay.
Neuronavigation, it's just like it's the GPS of the brain.
Okay.
You are going to some place, you don't know the location. You have a GPS tracker. You go through that and exactly go to that point and then reach the place. The same way, this acts as a GPS of the brain, wherein you are knowing before you enter into the brain the exact size, the shape, the structure, the location where you have to go into the brain, prevent normal neurological structures from being damaged, exactly know which major vessel to avoid, which major vessel, through which corridor you can go. The size of the surgery is very, incision is less. You don't need to do a huge craniotomy and then operate. We can go through a small incision and then get to the point. We can take biopsies from deep-seated areas with pinpoint precision. Pinpoint in the sense it is sub-millimeter precision.
Oh, excellent.
That way. So, it has influenced it in a great way. And another thing is with the AI coming in along with neuronavigation, there are ways in which in real time, while you are operating, you feed the CT scan, you feed the MRI to the patient, you feed the angiograms, and you know where the tumor is, you are operating. When you are operating on the patient, the part of the tumor will be removed and it is no longer corresponding to your previous MRI because that part of the tumor is already removed.
Okay.
So, the next part, which may collapse, it may go behind, you will not know whether it is really collapsed and you are behind there is some important structure which you should avoid. That is one of the drawbacks. Now, that has been circumvented by getting a real-time imaging.
Okay.
That is intraoperative MRIs, intraoperative CT scans with AI interventions, wherein the AI tells you very clearly while you are operating that within 2 millimeters on your right side, there is one blood vessel which should be avoided. Real time when you are operating. So that gives a great amount of information. So the amount of precision, the amount of safety the amount of neurological recovery without any damage to the patient is phenomenally increased. But it requires, and we in Brindavan have a neuro navigation. We are using that neuro navigation for all brain and spine pathologists.
Amazing. When you've spoken about Brindavan, so what varieties of surgeries, intervention is being done in Brindavan Hospital? Neurosurgery.
Neurosurgery, everything is being done. We cater to trauma, we cater to infections, we cater to tumors, benign tumors, spines, aneurysm surgeries, vascular problems, and everything is being done. It's just like a tertiary care center.
Okay. Any recent surgeries from neuro navigation at Brindavan?
We had one patient with glioma of the brain. That is stage 4 glioma. That is the last stage. Patient had been operated 2 times earlier elsewhere. And first time the major chunk of the tumor was removed, he became better. 1.5 years later, he had a recurrence. It was operated again somewhere else. And then he had another recurrence, because we know that glioblastomas do grow fast. Not that it was not done properly earlier. The tumor's location was very close to the motor cortex. That means the area of the brain which controls the movement. And it was on the left side. It's an eloquent area. So in that situation, that patient was not able to move his right upper limb, lower limb. He became almost paralyzed. And he came on a stretcher. We did the CT, we did the MRI. It was exactly just adjacent to the motor cortex. What we did was, we localized the tumor. We found out the extent of the tumor, the depth, the surrounding structures, and during surgery, believe it or not, just with millimeter precision, the whole tumor was removed, and lo and behold, he started walking third day.
Nice.
It's so satisfying actually.
When neuro navigation has come in, what is the role of awake craniotomies now?
It actually helps in awake. Neuro navigation helps in awake craniotomies.
Okay.
If it is in an eloquent area, and we have neuro navigation, we have awake craniotomy, we have functional mapping of the brain, where you can actually have different functions of the brain, and we have MRIs which can do tensor PET imaging, tensor DTI, that is diffusion tensor imaging, where it will exactly show whether a track which is carrying for example, a pyramidal track, it is the motor cortex, the pyramidal track going down. If there is a track in the normal situation, or if it is displaced because of the tumor, that we can know. And you think the track is here, but actually it is just medial or more lateral. You're not aware of it, then you may damage the track. So in order to prevent all those things, we have this diffusion tensor imaging. You have this neuro navigation and awake craniotomy. Awake craniotomies are like in eloquent areas. For example, a motor cortex, a person who is a violinist, who is a veena player, his hands are most important. And if it is in an area which can cause a damage to his hands, in the sense it can cause a paralysis, or his sensations come down, then he is actually, even though he does not have a gross deficit, he cannot lead a normal life for him. So in such situations, we actually tell them to talk, we tell them to sing, we tell them to move their fingers while we are operating. It is just under local anesthesia. We remove this bone flap, start operating on the tumor with neuro navigation. Okay. And then this particular person he's at a particular point of time, when you go in there, and if he says he's not able to talk properly, he has some stuttering, some slurring of speech, at that point, then you know that is the area which you should avoid. And it probably corresponds to the neuro navigation. And if you have real time, then it is much better. So that is how it helps in
really amazing
precision.
We have talked a lot about medical terminologies and all, but if we have to put into a synopsis for the public in their language about AI, robotics, and neuro navigation, how would you put it in a public can understand?
See, it has been the neurosurgery earlier and the neurosurgery now has become much more safer, precise, and the amount of damage or the opening of the brain or the skull will be very less. The recovery time is very less, and it is precision based, and it's affordable also. So that way, the layperson can know that brain surgery, spine surgery, I am finished, I am paralyzed for life. It's not so. Actually, it prevents you from further paralysis, from getting into a further damage by not getting operated, if at all an operation is necessary.
That's amazing. And another thing what public needs to know is a neurosurgical unit. It is not a one-man show. So who are your strength when you're working?
You are you are heading the team in intensive care, and I'm yet to find another good team which I've worked for the last 25 years. It's a really good team. We need a proper neurosurgeon, neurologist, intensive care, paramedical staff, nurses, ICU nurses. Everything is important. But basically, the core stuff is this much, and the OT. OT team must be knowing when it is an emergency, when it is not an emergency. Sometimes in the middle of the night, even if the nurse is not able to understand that there is a major problem going on, they say patient has got some bradycardia. Pupils are not very clearly reactive. I feel there is a problem. That much is enough for us. Rather than getting up in the morning and being told the patient's pupil are fully dilated. Then there is no point, you can't come salvage the patient. If we are told in that particular, so time is the essence. If you are told in that particular moment that there is a problem, then you have to react, and then immediately you can salvage the patient.
So what I can put across is knowing your neurosurgeon is the best, but knowing the team is much better for a better outcome.
You cannot operate, you cannot be a neurosurgeon without a team. It's impossible. It's not a one-man show. It's a team show. Everybody is contributing to that particular patient in their own way. And neurosurgeon may come and operate. But what about the rest? The proper anesthesia, proper pre-operative preparation, post-operative care, rehabilitation. Everything matters. You do a good job and the patient has some bleed and dies and he aspirates and dies. Or he has a problem, he's got no rehabilitation and he's not recovering properly, even though there was a chance that he could recover. All these things matter. So it's never a one-man show. No medical specialty is a one-man show. Everybody is dependent on another specialty in such a way that something has to be done by the other counterpart so that the wholesome treatment is given to a person.
That was an interesting discussion on neurosurgery, though I have tried to touch a small aspect of neurosurgery. I know neurosurgery is very vast, but it was a very interesting discussion. But coming to the final segments of myth and facts, let's bust some myth what public has. Probably I'm asking these questions based on the public views. Okay. Does brain surgery changes personality?
Not always. If it is a large problem within the brain, the frontal areas where there's some cognition are involved, it may. Not always.
Will paralysis happen after spine surgery?
No. No, again, not always. Because people are in the misconception spine surgery is equal to paralysis. It's not so. It actually prevents them from getting paralyzed at a later date. It is not equivalent to paralysis.
Once you get a slip disc, you can never exercise again.
Not so. If after the repair is done and the annular tears are repaired, the disc is properly treated, you can go back to exercises. But nevertheless, it should not be so very strenuous and it should not cause further damage upon the injured disc, with precautions.
Headaches always need brain scan.
Not necessary. We have discussed that. Okay.
Sitting posture alone causes this prolapse.
No. Sitting for long hours without any movement definitely takes a toll on the spine. Especially we have seen young IT individuals in their 30s coming for spine surgery with large discs. That is because they are not exposed to exercise. Their vitamin D levels are phenomenally low in 0, 2, 3, 4 levels. And they suddenly lift some weight and have a slip disc. And they're obese because their food habits are not good. Many times they don't exercise, they eat more and they put on weight. And these things are giving some problems.
In your years of experience, what are certain myths public carry?
Headache requires a scan. No, all headaches don't require a scan. And all weaknesses are not paralysis. They come with a Bell's palsy. They say, oh, I've got a major paralysis. It's not a paralysis. It is just a weakness of one side of the face. They have a facial deviation, they think it is a stroke. It's not so. And young children may not have any problem at all. It cannot be a tumor. No, children can have a tumor. They can have large medulloblastomas, and they can have large brain tumors which are not diagnosed. And it will be probably detected by a good teacher. They think that the child is not seeing properly, not giving proper attention, not able to speak out certain words effectively, not able to have good memory. So if she gives in, or he or she gives in a particular indication to the parent to just check it out, we find there are certain problems. And not all patients who go to psychiatrists don't have a tumor. We have been referred by psychiatrists after they have done a CT scan and being treated for probably a year or two for some psychological problem and for behavioral disorders. Frontal lobe tumors reach large sizes and they go to a psychiatrist first, thinking that there is a behavioral problem. They're not behaving normally. But they do a scan and find a large tumor, and then it comes to us as a large tumor.
So finally, coming to the last segment, you have to answer in one word. One symptoms people ignore too much.
Persistent weakness, headaches, which are progressive. It's a simple headache. I've been having this for a long time. No problem. That sort of a thing. No. Progressively severe headache, thunderclap headaches.
Most overrated spine advice.
Oh, you'll get a paralysis after such. That's wrong.
One daily habit harming the brain.
Not exercising, eating too much, being more sedentary, not getting into new things. You have to go into something you're not familiar with. As you age, brain knows there are pathways already defined in the brain. So you need to explore into new arenas which you have not done earlier. So start writing with your left hand, start brushing with your left side. So you try to become more ambidextrous, and that will stimulate so many neurons which were probably dormant.
Coffee before surgical rounds.
Medicine to the doctor before giving medicine to the patient.
Brain versus spine surgery, which is your favorite?
Well, both. Brain because of precision and spine because of structural integrity.
One thing everyone should do for brain health.
Walk, at least some exercise.
Okay.
Walk in the sense some physical activity.
Okay.
It has been very clearly demonstrated that the brain-derived neurotropic factors, BDNFs, phenomenally increase. Your Alzheimer's after 60-65 reduces.
Okay.
Your memory gets retained. And you try to learn some new language, like French or German or Sanskrit or something, which you are not aware of.
Okay.
And the number of neurons which get stimulated by that, and the type of cognition you get and the type of awareness you get is really good. And it has been proved with studies.
It's amazing. That's an interesting one. Right? And one thing everyone should stop doing immediately.
Stop doing it. Too much of mobile. They get a severe, it's causing a lot of problems, both in children, in adults, everybody.
Okay.
Too much of screen time.
That was an amazing discussion on neurosurgery and its intervention and its role in different aspects. So thank you very much, sir, for this interesting and
so
detailed discussion of neurosurgery.
Yes, it was really good talking to you. It was very nice. And we in Brindavan have a very good team here, and we can do much more and for the benefit of the public.
Thank you so much.
Thank you so much.
Today's conversation highlights something very important. Your body always gives signals. The real question is, are you listening? Brain and spine issues are not something to delay or guess. The earlier you act, the better the outcome. Thank you so much, Dr. Anil Sangli, for coming here and giving such a interesting description on neurosurgery and its intervention.
Thank you. Thank you so much.